So I wanted to put up a video about how we manage our patients, what it is that we're looking at, how we go through bloods, symptoms, etc. So what I've done is I've written what a typical thyroid case looks like. This is not based on any one person. It's a sort of amalgamation, I suppose, of a typical patient that we see. I'm going to take you through how we sort of go through history, symptoms, and then the blood results, and then what I would sort of look at in terms of an impression and a plan. So, history. This is a 45-year-old woman, been on levothyroxine for 20 years, feels wired but tired, wired and exhausted. She's having palpitations. She's heat intolerant. She feels quite low in mood and has poor motivation. Can't be asked to do anything, quite frankly. Brain fog, and finding it very embarrassing, the whole brain fog thing. Has been seeing her GP for around 12 months about all of this, and GP's just saying, you need to go on antidepressants, you're depressed. She doesn't want to. She's not keen on going on antidepressants at all. Gynecological history, she has 2 children, she got pregnant very easily. Her periods have got increasingly heavy, but are still regular, but also finding that signs of PMT are worsening in and around her period and her ovulation time. So PMT symptoms tend to be irritable mood, bloating of your belly, sore breasts, that sort of a thing. So she's finding that those are getting worse. So once that tends to be what the sort of history I get when I first see a patient coming in. They tend to write me that sort of history. Then I want to know much more about a person in the whole. So I tend to then ask about things like bowels and sleep. So for this lady, her bowels are sluggish. They're never brilliant. Sleep, she just feels like she could sleep forever, but then wakes at 3 to 4 in the morning most days. Never feels refreshed. You know that feeling? Never refreshed when you wake up in the morning. Social history. So by that means smoking, drinking, what you do, what your life is. So she doesn't smoke, barely drinks, and she is a lawyer. Family history. Family history is so important in a thyroid history. That's because not everyone, if we've got Hashimoto's, not everyone has positive thyroid antibodies at the time of testing. But if we know that there's a family history of thyroid issues, then that tells us it gives a massive clue, basically. So in this fake case, the mother has thyroid issues too. Past medical history, nothing else relevant. And she's taking levothyroxine 100, zinc and selenium, which are there to help conversion, and vitamin D at 800 international units per day. Just as a side note, she is high functioning and has a high stress baseline. In other words, like many of us who I see in the clinic, and quite frankly me, she has kids, high functioning job, very high levels of stress, plus a thyroid disease. So we've gone through the history in quite a systematic way. I'm already, by this point, full of ideas, and generally when you see me in your consultations, I'm generally at this point desperate to start telling you things and wanting to tell you exactly what's going on. But then we need to look at your bloods. So thyroid bloods, TSH 1.1, T3 3.5, T4 18. Thyroid peroxidase antibodies are negative. Thyroid globule antibodies, the TGA, are high. So if we look immediately at the thyroid, when I look at thyroid bloods, I first of all look at antibodies. Now, we test 2 types of antibodies, thyroid peroxidase and thyroid globulin. In the NHS, because of the thyroid cancer overlap, they only test thyroid peroxidase antibodies. So if she had gone to her GP, there's a high chance she would never have been diagnosed with Hashimoto's in the first place. She may have, because her thyroid peroxidase antibodies are negative. Obviously, in this fake case, she managed to get herself treated. So it may have been at some point that her TSH was so awful, so high, that the GP went and did something about it. But there is a chance that if it had never got that bad, because her antibodies are negative, her one antibody are negative, she would never have got treatment at all. We miss a lot of Hashimoto's patients by not testing thyroglobulin antibodies. So that's the first thing. I look at thyroid antibodies first. So she has thyroglobulin, negative thyroid peroxidase. She has Hashimoto's, full stop. Now, why is that relevant? The reason that knowing Hashimoto's is relevant is because it is a progressive disorder. So we know that over time, that thyroid is getting more and more destroyed by the antibodies. Why is that relevant? Because your thyroid produces 5 hormones, not just one. It produces T4. It produces about 10 to 20% of the circulating T3. It produces T2 and T1, which help convert T4 to T3 hormone. T3 is the active hormone. I have said this in so many videos. If you watch them all, you're going to be very bored of this. And then the 5th one is something called calcitonin, which helps with processing of vitamin D. So if she has Hashimoto's, the thyroid that's producing 5 hormones is being gradually destroyed, and therefore it's not just stopping making one of the hormones, it's stopping making all 5. So she's going to lose that 10 to 20% of her circulating T3, plus the hormones that are helping convert T4 to T3 in the first place, plus the calcitonin. Okay, just something to think about. So she has Hashimoto's. We've worked that bit out. I'm now thinking, okay, she's probably going to need some T3 if she's in the state she's in. So then I go to the T3 and the T4 results. Note I haven't even looked at a TSH yet. So I look at the T3 and the T4. When I'm looking at those hormones, with the labs that I use, I know that there should be roughly a ratio of T4, a ratio of 4 to 1 of T4 to T3. So in other words, if a T4 is around 20, I would hope and expect a T3 is at least 5. So this lady has a T4 of 18 and a T3 of 3.5. I can see immediately with my maths hat that she is not converting T4 to T3 very well. And in actual fact, her T3 is really quite low. And that's why she's not feeling very well. Because why? Because T3 is the active hormone. TSH 1.1, it's fine. Again, if we were looking at where she would normally be tested, they would be looking at the TSH and the T4, and you would think she's euthyroid. Now, this is not about saying that the NHS is doing it wrong. The NHS is doing it within the bounds that the NHS can do, but it doesn't help everybody. So they would think, you're fine, carry on, thyroid's fine, this isn't a thyroid problem. Okay, so let's keep that bit in our minds. Then I'd look at your vitamins and minerals. So on her case, we had a vitamin D that's low. So I want a vitamin D to be greater than 100. So 56 is borderline very low, and it's certainly not optimal. Why is thyroid patients vitamin D, and still I have not had a single patient through my clinic with a normal vitamin D unless they have been highly supplementing. Why? Partly because of the calcitonin, so you're lacking in calcitonin. Partly also because one of the thyroid hormones functions is to help us absorb vitamins. Also, quite often patients just don't feel well enough to be outside. Also, a 4th point, actually if you were to test an awful lot of people's vitamin Ds, even without a thyroid problem, a lot of them would be low. We just live in a country where there's not enough sun. Then we've got a ferritin, that's iron level. Ferritin is also low of optimal. Again, this might be considered a normal level at 27. For me, I want it greater than 50. So it's too low. And if I can get a woman's iron greater than 50, I'm happy. Lots of the internet comments about iron and thyroid is that it should be as high as possible. Yes, I agree, but the reality is that women do not hold on to iron very well. So I am happy if I can get it greater than 50. Iron tablets are not very nice to take, and we still haven't really found a good way of getting iron supplementation on board, short of having an iron infusion, which are expensive and not readily available on the NHS. So that's iron. So vitamin D is low, iron's low. Folate's normal. Active vitamin B12 is normal. And then note that is an active vitamin B12. We only test an active vitamin B12 these days because, a bit like testing only a T4 without a T3, there's no point testing a total vitamin B12 because that's not telling me what actual active B12 there is in your system. So next we would then look at sex hormones. So when I have all of my initial consultation patients, they all have these 3 sets of blood. So thyroid and vitamins, sex hormones and cortisol. So this is all the results that we would be getting. So sex hormones. So for her, she's got an LH and an FSH. That's LH is relatively high, FSH is normal. Her estradiol is quite high. Now the way that the LH and the FSH pattern are, with the high estradiol, she's at ovulation point. It's quite common in ladies of her age, I think she was 45, I've forgotten already, to end up with slightly higher estradiols at ovulation point than some if you were younger. That's because essentially your body's trying to push out eggs as much as it possibly can. So that's quite a high estradiol, but it's completely normal for ovulation point. Testosterone levels are starting to drop. Prolactin levels are good. Then we do a cortisol saliva test. Now, the reason we do a cortisol saliva and not a blood one is because the blood cortisol to saliva tests are there looking for true adrenal issues. So Addison's or Cushing's. So Addison's is a lack of cortisol in the body, and Cushing's is too much cortisol in the body, and they are true adrenal pathology. A cortisol saliva test can pick those up, but are not diagnostic of it. So if their cortisol tests are very, very high or very, very low, I would be suspicious and ask them to do a cortisol blood test. But where a cortisol saliva test is better than a blood test is that it gives us a nuance. It gives us an idea of what those cortisol levels are doing throughout a day. And if we were to plot those on a little graph, they should look like, I always go to a mountain, a ski slope. So you have, when you're skiing, you have different steepness of mountains. So there's black runs, which are really, really steep and hard, red runs, which are sort of in between, blue runs and green ones, which are basic, and then you have baby runs, which are pretty much flat. So a normal cortisol, I have a simple brain, I have to remember these things in simple ways. A normal cortisol should look like a red run. So it's like a sort of steepish mountain that goes down and then settles into it as you get to the bottom of the mountain, so nice and flat. With hers, if we were to plot those markers, they would look a bit like maybe a green run, so a slightly highish mountain, but really not entirely, not a baby mountain, but just a little bit. And that isn't the way it should be. It should be this red steep mountain. So her morning cortisol is a little bit low. I'll come on to what that means in a minute. So I would then look at what my thoughts are, what the impression is of what's going on. So again, we split it into the things that we've tested. So thyroid, she's Hashimoto's. She is biochemically normal. In other words, if we were to just test a TSH and a T4, she's normal. Even with a T3, she's technically within the normal range, but if we look at the actual rate of conversion, her T4 to T3 conversion is only 5.14. Remember, it should be less than 4. So she does not convert levothyroxine well into T3. I'm going to skip the cortisol a minute. Vitamins and minerals, I put them in the wrong order. Vitamins and minerals, suboptimal vitamin D and a low ferritin. So they don't help because that in itself will impair thyroid function, but most importantly also recovery. So that needs treating. Cortisol, we've talked about that low morning cortisol. She's wired and tired. So often patients come to me with symptoms like she's describing, where she feels wired and tired, and they think that they're hyperthyroid, they think that they're overtreated, when actually they're not necessarily hypothyroid, but their balance, their active T3 hormone is lower than it should be. And so actually the underneath is a technical hypothyroidism. And then what happens, and this is very, very basic physiology, well, it isn't, it's very high level physiology that I'm going to put in a very simple way. Your thyroid literally affects every single cell of your body. If that's not as it should be, your body then has to rely on cortisol and adrenaline, which are produced by the adrenals and monitored by your brain. If your body's had to rely on cortisol for a very, very long time, high levels of it, and remember, she was a very high stress baseline. She's got kids, she's in a high powerful job. So if they've been living on cortisol for a very, very long time, the body gets to a point where it says, I just can't keep producing that high level of cortisol. And eventually those cortisols start to go low. And that tends to give us this wired and tired pattern. Also quite often, once you've got to that point, once your cortisol start to go low, you start to kick in and have adrenaline shots. And those adrenaline shots tend to wake you up between 3 and 4 in the morning. So all of this suddenly starts sitting together. We've got autonomic nervous system disruption, or HPA axis dysregulation. They're effectively talking about the same thing. The cortisol is the product of that. It isn't the cause. The cortisol is the product of this wired and tired autonomic nervous issue. HPA, by the way, stands for hypopituitary thalamic adrenal axis. It's basically the pathway between your brain and your adrenals. Sex hormones. So for her sex hormones are normal for ovulation time. Testosterone starting to go down. If we listen to what she's saying, she's likely perimenopausal. She's classic age for perimenopause anyway, and this will be contributing to her mood and her thermoregulation symptoms. So feeling overwhelmed, hot flushes, etc. Why that is also particularly interesting is because it is so common that around the time of perimenopause symptoms really kicking in, that's also the time when the thyroid symptoms really start to go off. When I look at my patients that I have, the main times I see people, women mainly, is in and around puberty. What's happening in puberty? Massive sex hormone changes. In and around kids, as in having kids, massive sex hormone changes. But most times is in and around perimenopause and menopause. And we don't entirely know what is going on because, quite frankly, we haven't studied enough into female health and hormones. But we know that that huge change in sex hormones causes a massive impact on our bodies, causes an extra stress, internal stress on our body, and then that has a massive impact on our thyroid. So if you want to almost work upwards, we may find that actually what happened was the perimenopausal side of things started first. That then affected her cortisol, and that then affected thyroid, which then affected cortisol more, which then affected sex hormones more, and on we go. And with that, vitamins start to decline. So a plan. I hope this makes sense to you. Our plan. If I was seeing her, I would be talking about introducing some sort of T3, whether that's being adding liothyronine on top of the levothyroxine, or switching onto a natural desiccated thyroid, Alma thyroid. She needs something, definitely. We would look at correcting her iron and her vitamin D deficiency. So generally I recommend iron bisglycinate. That's because it's better tolerated and better absorbed. And by taking it 3 times a week with vitamin C at night, because it's the one thing that actually interacts with thyroid hormone, but that high dose 3 times a week gives us 30% extra absorption of iron, but 30% less symptoms. We're going to be taking high dose vitamin D. Now, 800 international units, which she was on, is nothing. It is considered a high dose, and is generally what GPs recommend. It is not high dose. You can see that her vitamin D was only 56. She needs probably 8,000 international units for a few weeks and then dropping down. Most thyroid patients find that we need 4,000 international units in the winter and 2,000 in the summer. Sex hormones. Yes, she would probably benefit massively for some HRT and possibly some testosterone in time. But the first thing we need to do is get her thyroid right. And again, we're back to a sort of system level, simple brain again. Thyroid is the foundation. If we're building a foundation, it needs to be secure. At the moment, hers isn't. And if we add HRT on top of this wobbly foundation, it won't work in the way we want it to do. So we need to get that thyroid right first. Once we've got that thyroid right, we can reassess. We can reassess her symptoms. We can see if she's feeling better. If she's still having hot flushes, she may at that point decide, actually, I would like some HRT, please, but I feel a lot better otherwise. Equally, she may find that actually she can cope with the menopause, perimenopausal symptoms, and we just carry on until a point she can't. Either's fine, but until we sort that thyroid out first, that HRT is always going to be a bit wobbly. Cortisol. Probably the biggest question I'm asked about is what can we do about cortisol? Now, we've already said, haven't we, that she has a low morning cortisol. That will be because her thyroid is not doing what it needs to do to get her up and get the systems going. And her system's given up trying to produce so much high cortisol. So that pattern is consistent with dysregulation, not failure. So by that, I mean this is not Addison's or Cushing's. Fundamentally, if we were to give her cortisol for that low cortisol without it being pathology, we are going to take over from a functioning gland. We don't want to do that. We would stop that adrenal producing cortisol itself, then she would be dependent upon cortisol for the rest of her life. Bad idea. So I don't treat cortisols. I've never given hydrocortisone, and I never will unless they've got a true cortisol deficiency. Different beast. What we need to do is correct the hormone imbalances that we've got, correct the vitamin imbalances that we've got, perhaps give us some adaptogenics. Adaptogenics will help the symptoms of low or high cortisol. They do not correct the actual cortisols themselves, apart from ashwagandha, which actually can lower cortisol. So she would not be taking ashwagandha. But the thing that sorts out cortisol is time, rest, managing stress as much as is humanly possible, and sorting out the underlying hormonal problem. Often I say, please do not retest your cortisol again until at least a year down the line. And that is because cortisol tests themselves cause stress, and I don't want any more stress on top of everything. I've just written a whole series of essays on autonomic cortisol dysfunction, dysregulation. They're worth a read. They're often frustrating symptoms to manage because actually there isn't anything that I can do. But sometimes if you can understand what's going on underneath, that then gives you the power yourself to manage it. So have a read of those if you're interested. So overall, we're going to be introducing some T3, hoping that sorts out her thyroid. We would then re-see her again in about 3 months' time, see how her symptoms are, see how her bloods are. I'm generally aiming for a T3 between 5.5 and 6.5. Care a little bit less about the T4 levels. Correcting the iron, the vitamin D, and then just monitoring. We would generally see this patient 3 monthly for a good year or so at least, and then go down to 4 monthly, and then 6 monthly once we've got you stable. I hope that's helpful for you. I'm always aiming to just give as much information as I can so you can have a really, really good understanding of what's going on in yourself. Take care.